Hey guys. So friend. Okay. Um, I'm Zoe Weinstein. I am an addiction medicine physician at Boston Medical Center, and I'm also the site medical director of the Bradston OTP clinic, which makes me infamous. I will acknowledge. I also want to acknowledge that some of these slides came from a workshop I co-presented with many excellent people at the ASAM National Conference. So I just want to acknowledge all of them. Great. So I'm going to go briefly through the evidence for our current outpatient methadone titration, talk a little bit about how fentanyl pharmacokinetics and those implications for the dosing that we do, and then talk about some emerging inpatient and outpatient, more rapid induction strategies and how that could inform our outpatient practices. Hopefully this goes without being said. I think it highlights a lot of what Dee already said, which is that we really need to get methadone treatment right. This is one of our 3 FDA approved medications in the United States, one of the 2 that prevent overdose and death. It is a life-saving, infection-preventing medication, and we really need to use it in all those people who are not being treated, as Dee highlighted. And early treatment is a critical window for treatment retention. And adequate dosing is important determination of treatment retention. So just kind of drawing those dots together for you guys. So the longtime standard of care and what all of us were taught about methadone, unless you're a fellow in the room and just got taught yesterday, was probably to go low and slow. That this is a dangerous medication, that it's pharmacokinetics, or that it has a long half-life. It takes 3 to 5 days to peak. And so we have to go and titrate it slowly, and we have to have a healthy respect for the medication, which that all still is true. I think, as Ruth highlighted, some of our knowledge about this has then become codified in policies and procedures at the clinic level. And some others, so we might have titration schedules that are set by clinic policy and procedure, or that we might think are set by clinic policy and procedure, as Ruth highlighted. And then there are other things that might happen to patients at their clinics, for example, automatic dose decreases for missed days. And the cumulative effect of that is that patients may really struggle to get on a therapeutic dose early on and struggle to stay on a therapeutic dose during their treatment, which, as you know, we are all concerned about that being a deadly outcome. And I do want to acknowledge that our traditional induction strategies are based in evidence and science. It's just very, very old evidence. Okay, so, and I went back and I read some papers from the 70s, and there's one on the slide from the 90s. Okay, and I'm not gonna tell you how old then, but I was not a doctor. And there were things happening in the 90s that I was not aware of, like these international reports of overdose deaths that were happening in the UK, especially in the first 2 weeks of treatment. And these very damaging papers about the risks of methadone, saying that actually the overdose risk in the first few weeks of treatment was even higher than people not on treatment. There are a lot of methodological concerns that I have about that paper now that I've read it. And so you all can read it. We can have a journal club. But I think to say that it's a little unclear if that's actually true. I will say that, there is newer data, again, from the 2010s, saying that the early weeks of treatment are definitely the most dangerous time in terms of people's overdose risk. I don't think more dangerous than being on no treatment, but still the most dangerous time is the first few weeks of treatment. And the concern is that we are too rapidly titrating methadone. We're getting dose stacking of methadone, and patients are getting, the overdose is driven by the methadone itself. And so thus we must be cautious with the methadone. I'll also say that there was data about prescription methadone. You've heard methadone is available in pharmacies for pain, and that in the 2010s, when there was much more prescribing of methadone for pain, that there were a large number of overdose deaths from methadone. But whether those were OTP related is probably unlikely. And so I think what all of this is to say is that we should understand that methadone, like any opioid, has overdose potential. And every day when I start a patient on methadone, I counsel them about that. And especially with the long acting half-life of methadone. However, we really need to balance that risk of the methadone dose itself with the risk of a subtherapeutic dose, continued use, especially in the era of fentanyl, when, as you can see, all of this data is way pre-fentanyl and drug supply here internationally. And so again, this is what I was taught. I think this was actually the paper I was told to read before I started as a fellow at the methadone clinic about how methadone works. And it was written in 2003, and I started working in the methadone clinic in 2014. And this was like the up-to-date paper that I was told to read. And I probably like still give it to the fellows, I don't think so. Sorry. But you know, this is the pharmacokinetics that, again, we the fentanyl, the drug supply is different, but methadone is the same. Okay, this is the pharmacokinetics, and these at the time were the ways we were told to start methadone, and these are some of the international kind of comparators of how to start methadone. And I'll give some caveats, some of this, but it says, in the US, you start at 30, you could go up to 40, and in the UK, you're giving, 10 to 20, depending on tolerance. And again, so you can see most people are in that like 10 to 40 range on the first day, and then slowly titrating, with 3 to 5 day intervals was kind of the universal standard. And so this is from tip 63, which, if you all have not read it, is like the Bible of treatment for opioid use disorder. This also includes some ASAM expert guidance. And this is what, again, we've all been taught, which is, the first dose you give between 10 and 30. 30 was, has been kind of anchored as the maximum single dose. And then 40, you can reassess, give an additional 10, give the 40, unless with additional documentation. And I wish I had put in a slide, because I like to put in slide emails that I get from BSAS. But BSAS recently sent us an email reminding us that actually this is not a hard ceiling, and that actually you can use any dose that you want with appropriate documentation. And I really appreciate, I think there's, as Bruce said earlier, there's a lot of misinformation about what the rules say, and that there is a lot actually more flexibility. And when I was coming up, I was really thought that 30 was like a hard ceiling, and there was nothing I could do about it. And that's really not the case. And like everything in medicine, you just document the crap out of it, and you can do what you need to do. I think that's just really important. I just want to highlight that we're very lucky to have a SOTA that wants to remind us of the flexibility of the regulations, because I don't think that is true nationally. And then how are we titrating the dose? So the ASAM expert panel kind of guidance that's in tip 63 is that we go up by 5 milligrams or less every 5 or more days. And then sometimes you could go slower, faster, 5 to 10 milligrams, no more frequently than every 3 days. And that's kind of in the first couple of weeks of treatment, that early phase of the induction, and then 5 milligrams every 3 to 5 days in week 3 and 4. So just so you know, that's what I was taught, and that's what I did till probably a few years ago, because I was a good soldier. I will say okay, everyone knows I'm not a good soldier, but so I still did it. But anyway. And that really dove deep, because I went into the ATOD training guidance. Okay, guys, I was like real reading. And I was like, what? I think there's also this mythology of like, what are we supposed to do or what to say? And I really read, what exactly does ATOD, teach us? Which, if you don't know, this is an association that represents over 1,000 OTPs, and they provide provider training. And what they suggested, which I thought was really interesting, was potentially that you could do more rapid titrations if you observe the patient at peak of dose, which is, if you guys don't know, that's usually 3 to 6 hours after the dose in someone who's a normal metabolizer of methadone. And that you could potentially titrate them daily if you were able to observe them at the peak, which again, no one had ever suggested to me in my kind of early training. And then a more slower later titration. So I will just say that there are some limitations in the evidence we have comparing different titration protocols, how fast to go, when to make the dose changes. And many of the studies are like literally 50 plus years old. I don't know where you were 50 years ago. I was not here. But so just balancing those risks of methadone and our current drug supply. And I think also just calling out that the fact that, as was mentioned earlier, probably structural racism and a few other things contribute to our lack of evidence and lack of study about what is even done clinic to clinic. And Ruth talked about siloing, and I think a lot of us don't really even know what our neighbor methadone clinic is doing. What doses do they typically start at? How fast do they titrate? And when you get a bunch of OTP directors in a room, it's like really mind-blowing the differences and how people provide care, which is not the same, right? If you're admitted to a hospital for heart failure, it's not like, what does your doctor do when you have heart failure? Oh, that's fascinating. That's the opposite of what, like, so, so it really just shows how stigmatized the disease of addiction is. It shows how stigmatized this medication is, that there's so much heterogeneity and people don't even know that there is because people are not talking to each other or people are afraid to ask, and how disempowered our patients are to kind of speak up and say, hey, that's not what was happening down the street. Maybe you guys should read it, like some literature. I will say that there's again, not super recent, 2009 meta-analysis of some methadone dosing. They looked at 18 RCTs again, which were, many of them were very old. And they looked at, methadone dose. And this was at 60, less than 60 or more than 60. And I want to remind you, some of these older studies, they're like, had very low therapeutic doses. And they looked at that, and they looked at whether there was flexible dosing, structural, like whether basically it was more patient-centered care. And the long and the short of it is that giving higher doses and giving more individualized treatment works better. So in case you were not sure about that, there is a meta-analysis that you can show people. I will mention fentanyl, as I mentioned a few times. If those of you are not aware, it is a opioid. It has a high receptor affinity. It is lipophilic. It has slow liver metabolism. It is much more potent than heroin, and there's even more potent kind of fentanyl analogs in our drug supply. And we're very concerned that people then develop even higher tolerance to opioids, and then have even more frequent need to inject, because even though it has at lipophilicity, it is a kind of more rapid on and off. I will say that methadone still works for people who use fentanyl. Like, that was a question, I guess, at one point. And there has been some expert guidance from Canada talking about how maybe we need to more rapidly titrate people's doses in the era of fentanyl. And they said, at least start at 30, and then maybe go faster, 10 or 15 every 3 days. Especially for people who are at lower risk of methadone toxicity. So younger, healthier people with a healthy liver, maybe we should go faster. If you haven't read this, it's a great, it's from Metaphy in Canada. Shout out to our Canadian friends. I know some of them are in the audience. And again, I would say this is not, at this point, probably very earth shattering, but I can say compared to some of those older traditional recommendations, I'm telling you, this is even more progressive. And definitely at some point, probably around 2021, I started saying, hey, instead of increasing people by 5s, I'm gonna start increasing people by 10s, like basically all the time, unless they're old and have cirrhosis and also use benzos and whatever. But if they're like a young, healthy-ish person, I'm gonna start going up by 10s. Like, why did I ever go up by 5s? And now it's like a rare day when I go up by 5. And again, it's for someone who's like 70 with cirrhosis. So just to say, like, even these small incremental changes, I think, did start happening in some practices now a couple of years ago. And then again, this study was by Stone, I think, in Rhode Island, I believe. And they looked at, does methadone treatment work as well for people using fentanyl? And they did a little bit more rapid titration than, again, what's in the tip 63. They did starting at 30 and a 10 milligram a day increase up to 50. Then they held them at that for like a week, and then basically went up by 20 milligrams a week up to a therapeutic dose. So just to say that they did kind of a little bit more rapid than what is in the tip 63, and they had good, I guess we'll say similar retention rates, 50% at a year. Obviously, there's a lot of problems with OTP treatment retention that I will not solve this talk. But maybe getting people to a therapeutic dose would help. I will also say what I think has really informed my practice and my kind of treatment community's practice is as more doctors who are coming more experienced and APPs who are becoming more experienced with methadone. So we have these addiction consult services where people are starting and managing methadone in the hospital, a medicine they may have never managed otherwise for opioid use disorder. And we have bridge clinics where people are doing a 72-hour rule methadone induction, again, with a group of providers who may or may not have ever stepped into an OTP and may have never otherwise managed methadone. And I think this expanded knowledge and comfort with this medication and being in a setting, for example, in the hospital where you can actually monitor the patient, actually see them at their peak, has really made people say, hey, maybe I can be a little bit more aggressive with this medication. I'm becoming more comfortable with this medication. This is an example of a paper from our bridge clinic at Boston Medical Center, led by Jessica Taylor as director. And again, showing that they basically were starting people when they first started out, kind of like 30-ish a day, then kind of 37 a day, 42 a day. And now their standard is really to do 40, 50, 60 for basically every patient, unless there's a medical contraindication like severe alcohol use disorder, or benzo use disorder, like I said, liver disease, severe pulmonary disease, where there really is a concern. They basically, unless there's a concern, they do 40, 50, 60. And for some patients, they're doing even more aggressively 40, 60, 80, day 1, day 2, day 3. And I'll say that in the inpatient, we have a policy that is very conservative that we tell our non-addiction specialists about how to start methadone. And the way we teach them to do it is the way that the textbook says to do it. But that's not the way that we do it. That's what I teach our fellows all the time. You are the addiction expert. You can do whatever you want. You don't have to, as long as your attending says okay. But, we have some patients that we put up to 70 on day 1. They're not like any old patient. I've never met this person. It's like, I know this person. I know their tolerance. I know they're going to leave and maybe overdose and die and have their endocarditis untreated if I don't titrate them. I don't give them 70 all at once. I have I can do it over 24 hours in a hospital. But just to say that we have patients that we very aggressively up titrate with supervision. And then at some point, I would say most places, once you get to around 80, I think the general consensus now is that you should hold that dose for some days to make sure that you reach steady state. I'll say that there's a couple publications, and I bet Evan's going to cover this too, that just look at more rapid inpatient protocols. Again, this is a 25 patient review, and you can see that they kind of did basically a 40, 50, 30, 40, 50, 60 kind of over 10 milligrams a day up to kind of get people to a stable dose. And they had very minimal adverse events, and they had 2 instances of sedation, but not even enough that they had to withhold medication. And another study, again, looking at 98 patients and inpatient protocol, which again is showing basically these kind of 10 milligram a day titrations up to 50 or 60. So again, people just becoming more comfortable with these more rapid protocols. I'll say our friends at San Francisco General are really doing it. I keep telling them to publish this paper. Hopefully someday they will, but they are really going for it. And they just got fentanyl like a day ago, guys. But they go, I'm telling you, 40, 60, 80, and they hold the 80 for 3 to 5 days. Like I said, I think that's everyone, I think we have to have a healthy respect for the medicine. I'm not disagreeing with that. But this is what they're doing. And, again, they're thinking about, does this person have heart failure? Does this person have advanced COPD? Does this person have cirrhosis? I'm not saying you should do this blindly, quite the opposite. Again, with a healthy respect for the medication, with an individualized assessment, but this is what they're saying is their ceiling. So I think it's just about expanding where our ceiling is, and not that we do that with every patient every day, but that we say that's an option that I could consider in this individual treatment plan, like Dee was talking about. I do want to say, like I said, I work for Bradston OTP, which is part of the larger Baymark corporation, and I've been working with national partners as part of Baymark to develop a more rapid titration protocol in the era of fentanyl. It's something that we're piloting across the country at different OTPs, and pretty similar. And this was driven by the perceived need that really a lot of patients were not being on therapeutic doses, and a lot of patients were leaving treatment early. And so basically we are, it's not a formal study, it's like a pilot quality improvement project, but for patients who either use fentanyl or in a place where fentanyl is highly prevalent, who we think have a high opioid tolerance, who, we have relative exclusion criteria. They're not absolute exclusions, but again, reminding people to consider some of these relative medical contraindications. I definitely say for me, I don't super rapidly titrate a patient who's never been on methadone before ever, because it's just really hard to know. They might be one of those outlier slow metabolizers. Luckily, almost every patient I treat has been on methadone 10 times, so they can tell me what to do. But, if I have a treatment naive patient, that's probably not who I would, do a rapid titration on. And then, of course, other, medical comorbidities that influence their methadone metabolism, right? The same way we think about any other medication, we're thinking about drug interactions, we're thinking about that individual patient's, body and which organs are working or not working so well today, and, how they're presenting. And so we have a very high intensity protocol that is an option, which is basically the San Francisco protocol. I'll call it the 40, 60, 80. And I'll say not that many providers are doing that, but there's one who is doing it, and it seems to be working the best, honestly. And then we have a more moderate intensity, which is doing basically the 10 a day up to 80. And again, these are not, it's not required. This is an option of something to try. And then once we get to 80, we hold the dose for 3 days. So I guess this is just a call to action, a la Ruth, which is, whatever setting you're in, to try to think about how to be a change agent. If you work in an OTP, engage with your clinic leadership. Say, what are these policies and procedures and protocols? Can I update them? Even if you're part of a larger system, can you be part of a national group of providers to make some policies more nationally? Get to know your SOTA. If you're not, if they're right here, you go shake their hand. And call. And really, I think what I've learned the most is just really working with my different colleagues as best practices evolve, to say, what's working for you? What are you trying? What are you doing? What are you scared of? And trying to break down silos. What are you seeing in the hospital? What are you seeing in your bridge clinic? What are you seeing in your OTP? How can we communicate better about how to best care for this individual patient? And then I really liked how Dee presented the perspective of the patient, which I think is often very underheard. And so I really think, is there a way in your setting to support patient advisory board, users unions, other groups that might be able to tell us about the patient experience, right? Because we're treating patients, based on our clinical training, which is great, but that's really not the full picture. Okay. So I guess my final takeaways. How did I do? I did great with time. Just in case you didn't know, there's some emerging rapid titration methadone protocols for both inpatient and outpatient settings. There's really a lack of evidence for a lot of what we do, which is great if you are a junior investigator and want a whole career fixing things and learning about things. And I really think this is something so important that Ruth emphasized, which is that really learning what are the regulations, and what are, if you think that there is medically appropriate or medically necessary care and you cannot provide it because of a rule or regulation, step one, ask to see this rule or regulation. It is 99% of the time made up. Two, exist, it might be much more vague or gray or flexible than it's being advertised to you. And if it really is written as such and you think it's harmful, like I said, be part of the conversation about how to change that to whoever that is, whether it's your clinic, whether it's your SOTA, whether it's the federal government, whoever, the DEA would be great to work on that someday. But I think but I think the other point is there is a lot of flexibility of things we can do within the existing regulations. And it's really, really great that, you know, the state is now in line with the federal regs. I mean, Dee said that it makes a really big difference, not particularly to this, but like before that happened, in this state, you could only get up to 14 days of take homes, even though federally you could get 28. So if I want to give someone 28 bottles, I had to submit a waiver to the state and federal government to give them 28 bottles. So it makes a really big difference to our patients, like that we're as flexible as possible in all of these ways. And then again, always involving patients and trying to do shared decision making. Obviously, when you're doing these more rapid titrations, there is increased potential risk. And so you have to, you know, counsel patients about that. And consider, you know, it's really great that we can give more take homes, but I think if, for example, we're more rapidly titrating people, we probably do want to see them every day just to make sure they're safe. So balancing that, say, hey, I could titrate you faster, but I want to see you every day. If you really can't come in, maybe we should titrate you more slowly just so I can keep an eye on you. I think having those honest, open, patient-centered conversations, that's the goal, instead of saying you must put someone up to 80 on day 3. Anyways, that is, I think, all I have. So really,